Hi, this is Peter Eckman, a heart failure cardiologist from the Minneapolis Heart Institute. I appreciate the opportunity to present today. My disclosures involve Abbott Laboratories, Medtronic, and Daxor. All funds are donated, and I have no control over those funds. I'd like to start with a patient scenario. A 55-year-old woman with a mildly decreased ejection fraction, dilated ventricle, and moderate mitral regurgitation. She has no coronary disease but paroxysmal AFib. She's managed medically with some improvement in her left ventricular size. But unfortunately, by the age of 75, when we meet her, her ejection fraction has declined, her ventricle has dilated, and she now has severe mitral regurgitation with NYHA functional class 3 symptoms. She has a modest mean pressure gradient. On echo, I think you can appreciate that her right ventricular function is a bit impaired but not terrible. Her LV function is poor. And on color Doppler, we see her mitral regurgitation is severe. In clinic, she has hypotension, heart rate of 57. She's hyponatremic with mild renal dysfunction. Pulmonary artery catheter placement shows elevated filling pressures, pulmonary venous hypertension, and impaired cardiac index. Her hemodynamics improved on dobutamine, but due to the severity of her disease, we ultimately elected to evaluate her for ventricular assist device. When facing the question of whether to focus on the valve itself or the ventricle, there are a number of factors to consider. Clinical parameters such as the duration, etiology, and trajectory of heart failure can give some clues as to the potential for improvement. I think it's also essential to assess the adequacy and tolerance of medical therapy. Patients on very low doses may be on that because of poor tolerance, or it may be that there have been inadequate efforts to intensify medical therapy. Age, surgical history, and comorbidities also play a role in eligibility for any types of treatments, and eligibility for advanced therapies can be a factor as well. Presence of a left bundle branch block has been suggested to be potentially particularly important due to impact on the papillary muscles, and CRT should be considered as a treatment modality. Personally, I find hemodynamics particularly helpful in sorting this out. Obviously, imaging and anatomic parameters that go into a decision of whether or not someone is eligible for either transcatheter or surgical treatments to address their valve are important. And we'll leave those to the technical experts in those aspects. I think it's essential that valve specialists know a bit about how to treat the ventricle, and similarly, ventricle specialists such as myself need to be aware of outcomes and options of valve treatments. Along those lines, I think it's important for people to at least be aware of contemporary outcomes of ventricular assist device. This is from the Momentum 3 trial, showing with the centrifugal flow pump has a 75% freedom from disabling stroke, pump exchange, or death at 2 years, which is a quite good outcome relative to these patients with low ejection fraction dilated ventricles. Of note, although I certainly wouldn't advocate a ventricular assist device as a primary strategy for mitral regurgitation, many of these patients with severe ventricular disease have severe MR, and in a study of over 200 consecutive patients, including 43 with greater than moderate to severe mitral regurgitation, the vast majority had very much improved mitral regurgitation, as one might expect from the primary ventricular treatment. There was a study published recently from Italy looking at patients with a low ejection fraction, severe mitral regurgitation, very high fraction of NYHA functional class 4. Primary endpoint was whether they improved to NYHA functional class 1 or 2 and were not hospitalized within 12 months. And they found that the pulmonary artery pulsatility index was the best predictor, and particularly in patients for whom this was less than 2.5, lower indicating worse RV function, there was a very high rate of failure. And this may be one way to assess whether someone would succeed with primary valve treatment or if the ventricle should and needs to remain the primary focus. There was another recent study looking at the role of NT-proBNP, which is a nice biomarker estimating left-sided filling pressures. This is a pool of patients that were divided into tertiles of about 1,200, 2,800, and 6,300. And you can see that the patients in the lowest tertile were much more likely to improve their NYHA functional class, and their left atrial volume index also tended to improve. Another concept that has been, I think, an important part of the conversation is the idea of proportionate versus disproportionate mitral regurgitation. Conceptually, the concept here is that when secondary or functional mitral regurgitation is by definition due to a disease process in the left ventricle, if that's very dilated, you would anticipate some amount of mitral regurgitation. Needless to say, the characteristic treatments for LV failure, such as neurohormonal antagonists, CRT, revascularization, may reverse this remodeling and improve the mitral regurgitation. It's also expected that the EROA is dependent on the LV EDV and the LV ejection fraction. And so one would expect that patients with a low EF and dilated ventricle would need a very high regurgitant orifice area to approach the regurgitant fraction of 50% that people generally agree is characterization of severe mitral regurgitation. It's been proposed that this may explain the discrepant outcomes between COAPT and MITRA-FR. And in MITRA-FR, there were a number of patients that had a particularly dilated ventricle, whereas COAPT excluded more of these very dilated patients. This is predicated on the concept that the EROA is an accurate index of the hemodynamic severity of FMR, which may not be true, and it also has some measurement factors that make it subject to challenges in imaging, as do all modalities. Figure 2 shows the same concept on the left there, but when we look at the relationship between the regurgitant volume and the EDV, there's less difference. And the other factor that needs to be kept in mind with regard to the EROA is that it's also dependent on the pressure gradient, and it has been suggested that the LV EDV may have been underestimated in the COAPT trial. These parameters are three-dimensional concepts that are measured with two-dimensional imaging modalities, which poses some challenges. When COAPT was broken into subgroups, the orange dot and the figure in the upper right shows the patients that had what was thought to be proportionate MR based on LV EDV indexed and EROA had outcomes similar to MITRA-FR, whereas the risk of death or hospitalization was much lower in the patients that were thought to have more disproportionate MR. Milt-Packer recently wrote, "The evidence supports the utility of this framework, but is not at the point where it can be used as a decision tool in individual patients. Echo is variable, and these estimates can be very challenging. There's a lot of assumptions that need to be made, and as with the patient we discussed briefly earlier, atrial fibrillation makes this even more challenging." Overall, conceptually, the way I like to think about this is that it's a matter of the heart failure and valve teams working together. I believe it's important, certainly as a heart failure cardiologist, that the ventricle specialists be involved in consideration of FMR treatment, and that collaboration works both ways, that we learn from contemporary valve options and have other ways to help treat our patients. We have found that it's also helpful to have the heart failure cardiologists participate in the valve conference. One of the challenges that we sometimes run into is patients are often sent directly to the valve team for severe mitral regurgitation with an expectation that they'll have a procedure, and there's always some pressure to do what's been asked at the risk of leaving both the patient and the referring physician frustrated. As you can imagine, returning with a recommendation to increase the medications isn't always what people are hoping to hear. Our approach at the Minneapolis Heart Institute is that the heart failure team sees all patients with a low ejection fraction considering surgery or transcatheter treatment for their mitral valve disease. We do this to provide an independent evaluation. We confirm and or optimize medical therapy, which many think was an essential part of the success of COAPT. We evaluate patients for the role of cardiac resynchronization therapy, consider whether advanced therapies might be appropriate. We also participate in management during the evaluation process, which sometimes for investigational devices can take some time. We participate in pre-procedural optimization and also can help with management after the procedure with preparation for next steps if the result is suboptimal. I want to thank you for the invitation to speak today and would encourage you to contact me if you'd be interested in discussing this further. Thank you very much, and I hope you enjoy the rest of the conference.